day for this particular class. So we basically started, we're finishing up another course to your credit. I hope that, I'm trying to expand the slide here. So if you'll give me just a moment. There we go. So I hope Dr. Davis gave you some good insight yesterday with regard to the physical assessment. And as I told you at the very beginning of this class, there is going to be a little repetition. So today I'm going to basically we'll cover a little bit, some new material, but also going to overlap a little bit of hers. So if you looked at the slides, you can see that there was a little bit of overlap there. So from that perspective, you'll just have to bear with me, and hopefully it'll just reinforce what she presented. And also with regard to the pretest and post-test, I'm not going to have a separate pretest or post-test. We're going to do the post-test, which is basically a repeat of hers because it covered many of the same areas, and I just didn't see that we needed to have a duplicate post-test. This afternoon, what we'll do is that we will end up and give you a little bit of time for the post-test. I do know that there was some issues with regard to some of you on a few of the questions that the answers did not seem to make sense. Aiden, I think, corrected that. With what had happened was that the test had where it would shuffle the answers. So I know that on a couple of the questions, they had the shuffling showed that the first answer was all of the above. And so that didn't quite make sense. So I think that's been corrected. So let's go ahead and we'll go ahead and get started, start moving through. Again, what I'm going to do today is basically go through a systems assessment. And Aiden, if you'll check on maybe on Arnold's situation, you can check to see if there was an issue with the test being maybe needs to be opened or something. But we'll move on. And so let's start talking about what I'm going to do is I can't emphasize to you enough. We're doing physical assessment with the pharmacy students right now. And one of the things that I can't emphasize enough to you is that the power of observation can give you a lot of information, that won't be necessarily apparent on the patient's, subjective information or objective information you get. So there's some things we're going to go through today, and we'll talk about things that, could be clues to some sort of conditions. So again, as I told you the first day that we started physical assessment, is so many clinicians now, because of the course load and so forth, they walk in to see the patient and basically grade in their tablet that has the information on their computer or even just the medical chart. And so they're buried with their head in that, and they're actually not even looking up at the patient. And one of the things that is very important that can give you some useful information sometimes is observing the patient when the patient doesn't know that you're observing him. So one of the things is, as you walk in, or as the patient is walking back to you, or as you go get them, maybe they're sitting in the waiting room, is to observe them when you're in the waiting room as they walk back, when you walk into the room, things like that, to get an idea of some things that may be happening that they may not be aware of and would not necessarily tell you. So these are some observations that you should be aware of that can come into play. One other thing I'm going to note to you on is that most of these slides, if I've got the title of the slide highlighted in red, that is a slide that you're going to be, responsible for. So some of these slides, the way they're set up, I couldn't highlight them, so the title would be the entire slide. So just to give you an idea with regard to that. So sitting on the, let me get my mouse working here. Well, I lost you there for a minute. Hold on one second. Okay, hopefully I've got you now. All right. So one of the things when we are looking at after we get reoriented to this format here a little bit. So one of the things that you want to look for is when you walk in, and this may give you some insight into some things with regard to their mental status, is basically how are they sitting? We know that a lot of times, especially with the first visit or something like that, the people may be particularly nervous or anxious. So things that you would see, and maybe that's not part of the disease that they're there for, that they're exhibiting, but it may be part of the issue, and it still is important information. So one of the things is that, you want to see, are they sitting sort of erect, or you should see them normally sort of sitting up or relaxed position. And when relaxed position, sometimes you can see in today's society that they're actually just slumping down on the chair. I've seen that more and more, where that students come in and basically, they're sitting there and they're actually almost laying down in the chair. But what you should normally see, that they're either sitting up or seem to be in a relaxed position. Some clues of some other things going on. For example, if they're sitting on the edge of the chair, that could be that they're anxious. And so keep that in mind. If it's a bedridden patient or they're in bed, curled up in bed, the fetal position there can be a sign of anxiety there. Look at how tense their muscles are. For example, if they're really tense, look like they're fixing to jump, fixing to spring, these are indications of anxiety. Vigilance, their eyes are darting, side to side, seem to be very watchful. The muscles are tense, maybe restless pacing if they're going around. Typically, what we see is those type of symptoms represent some form of anxiety. But the other thing that could come into play would be hyperthyroidism. So hyperthyroidism, their metabolism is ramped up and they may be, going 90 miles an hour. What's another thing that from a standpoint of disease state that you guys would see could potentially show this type of, edge of the chair curled up, muscles tense, restless pacing? What other condition would we have that could fall into that category? All right. So one thing could be mania. They could be a state of mania. One thing you could also see where that it could be involved with drugs. Could be some other things there. So again, noticing as you walk in and how they're sitting, that is going to give you some an idea of what their mental state may be from a standpoint. If they're slumped in the chair, walking very slowly, dragging their feet, typically we're going to think about this could possibly be depression. It could be, may even be organic brain disease. Could be some other type of things we'll talk about a little bit later on today. But again, these are things that you want to look for, and these will possibly give you insight with regard to how to frame your questions and what type of questions to ask. Let's see. Here we go. All right. Did that jump? Yeah. Okay. All right. Another thing is when they're walking, and this is usually in older people, but it can be in younger people. The body movements seem to be very deliberate, very controlled, coordinated, voluntary, smooth, and even. That's what we expect to see. Is that when somebody, think about this, and this is one of the things that you guys ought to do. I was sort of this more so a few years ago, many years, when I first went into my graduate degree. I think I've told you, is I had a professor that one of the things that he said was that many times that as we have gotten more molecular in pharmacology and clinically and so forth, that we've forgotten our ability to observe. Whereas years ago that we didn't have the in-depth molecular type things, and so people observed more. And so that was reinforced to me more recently when basically I started doing self-defense and martial arts. Is one of the things they spent a lot of time telling us is basically we should observe our environment, observe the people around us. And I found that being a little bit more vigilant, you do see some things. And I found that, from a standpoint of when I'm going somewhere or even dealing with students, is it gives me a better assessment of that particular student and how well they're doing. So the thing is that we should see when people are walking that, they should, their movements, what they're doing should have a purpose. We should see that it's controlled, that the movements seem to be coordinated. They're voluntary. They're not like a nervous tick or anything like that. And they're very smooth, even movements. If those are not what we're seeing, then there's some other things that, the different type of behaviors we see could very well indicate some sort of underlying disease process. So one thing is, as I said earlier, if they're very restless and fidgety, their body movements seem to be hyperkinetic, seem to be a little over-exaggerated. This potentially is what we see in anxiety. Apathy, very slow movements, almost like they don't care. We can see this in depression. We can see it in organic brain disease. Abnormal postures, bizarre gestures. These are things that we may see in schizophrenics. But especially in older individuals and potentially in younger individuals that may have a history of drug abuse, one of the things that we will see is that we may see this. We may see Parkinson's movements. These are things that we see that several drugs may actually damage the basal ganglia. And by damaging the basal ganglia, there could very well be some issues where that we start getting early signs and tremors. One of the things we start looking for, especially, and we'll talk about this a little bit later today, one of the things we start looking for in particular is in older people, what signs and symptoms would you think things like Parkinson's disease would start showing up? Does anybody have an idea? Typically, we're going to see them at very, typically in the 50s, late 50s or 60s. If we see this from a perspective of much earlier, the prognosis is not good. But one of the things that we see is that with these abnormal body movements, tremors, tics, choreographic type of things, this could be indicative of Parkinson's disease, which is probably the most common thing that we would see. But also we would need to look and see if any of their meds could potentially be causing a drug-induced movement disorder. And the meds that we would be looking for there would be primarily the antipsychotic drugs. So those are the ones that we would definitely be, even though we may be using some of the antipsychotics to treat depression and things like that, any of the class of antipsychotic drugs. Also, we see some of the older antipsychotics like phenothiazine, or we see some of those that are used as anti-nausea drugs. Phenergan, for example, is one drug that may be used that can produce these type of disorders. So one of the things we may want to look is to see if there's a particular drug-induced reason, especially if we start seeing facial twitches and grimaces. Those are very characteristic of a lot of drug-induced disorders, and so that's something we want to be careful about. The drug, metoclopramide. Metoclopramide was really not used very frequently as an antipsychotic, but we saw metoclopramide used quite frequently, and we still do today see metoclopramide used to treat gastroparesis, which is they use it for its anti-nausea component. They also use it to stimulate GI mobility. And so the primary prescribers of metoclopramide are GI docs and general practitioners. And we started seeing the emergence of tardive dyskinesia in these older people. So one group of people that tend to get gastroparesis a lot are diabetics. Older women that are diabetic are at risk, particularly even more so. So what we saw is that metoclopramide worked pretty good by reducing the nausea and also improving the gastric motility. But one of the problems we ran into was that um, these women started developing tardive dyskinesia. And when you talk to the docs, what was interesting is the docs were saying, I'm not using this drug for a CNS use. I'm using it for a primarily for its peripheral use in the stomach. And we had to educate some of these docs with regard to, one, is that even though you're giving it to be used in the stomach, it's going to still get into the brain and get into the basal ganglia and can actually still cause tardive dyskinesia. The other thing we saw is that some of these facial twitches and grimaces, a lot of those docs said, well, these are old people, and older people typically have, these type of movement disorders. So they were just assuming that the symptoms of tardive dyskinesia were actually just symptoms of aging. So one of the things that we had to do is we had to focus on teaching these docs to recognize that these drugs, A, could cause this, and B, that these movement issues with the older people are not just age related. So the drug with the manufacturer, so they actually increased the warning on it. But the drug, when it was approved for treatment of gastroparesis, the statement is that the drug should never be used for longer than I think it was 3 months. And we saw a lot of people, since it was working so well, we saw a lot of people using it for longer than 3 months. So what we had here was we had a drug that could produce these type of effects that we recognized, but they were unrecognized by the doctors, the specialty that was using them, because their concept was, well, I'm only treating gastric issues. I'm not treating something in the brain. So again, it was some education, and finally the label actually changed. The other thing is that docs could easily use it off-label for a longer period of time, simply because that's prerogative. You guys know about off-label, which means basically if you have a rationale for using a drug for which it's not approved, you can do it. It puts you at a higher liability, but on the other hand, you can still do it. So again, you could come in, a patient could come in to see you about something or about these movement disorders, and you may find out that it was in fact due to another clinician prescribing a drug for this person's gastroparesis. All right, let's go to some other. Another thing to note is, are they appropriately addressed? Thinking about the setting they're coming to, this becomes a little bit more difficult sometimes in today's society, based upon some of the students that come to class at where I teach at, is sometimes you would be surprised at what they show up in. The season, their age, their gender, their social group. You're looking at, are they dressed appropriately? Are they, is their clothing fit? Is it arranged properly? Things like that. One thing that may be come into play, which is something that's come in recently, is one thing you might think is that, for example, I just learned, I should say, recently this last year, that some of our pharmacy students were coming to school and were literally homeless. Or were drifting from place to place because they were they put everything in to go into school. And, in the past, my thought process has been that basically if they're going to school, then they can come to pharmacy school, they can afford it. But we found that we do have a lot of students that are very, very, almost poverty level, but are still coming to school. So one of the things we look for is the dress, is their dress appropriate? If there is inappropriate, that could be brain syndrome that's there. This one I've seen a lot of situations with is where that my slide switched, where that the person shows up. I have a person that I know that has my phone number that drives me crazy sometimes, but she is schizophrenic, and when she goes off of her gets off of her meds, basically, she dresses very eccentrically, puts up on a lot of makeup, does a lot of things. Went into a bank here recently. I say recently, about 4 or 5 years ago, dressed very eccentrically, and handed the teller a note to give her all the money. And she thought it was a big joke. And she got arrested, and we had to deal with that. Our family had to deal with that. But eccentric dress and makeup could possibly be schizophrenia, manic syndrome, inappropriate for the season. This could be sometimes thyroid disorders. For example, we do know that hypothyroid people tend to be susceptible really to the cold. And so we would see that even going in a building or something like that in the middle of the summer, they may be wearing a winter coat because going into some of the office buildings, the temperature may be too cold for them. On the other hand, hyperthyroid metabolism is ramped up. They may be too hot all the time. So that's one of the things that we look at too. The clothing doesn't fit. We might look for example, that they recent weight gain loss. So the concerns would be eating disorders. Could potentially be a clue to that. Again, none of these are diagnostic. These are things that we look for. If the clothing is not buttoned or put on properly, shoes not tied, if it's on one side of the body, then it could be some sort of neural or skeletal disorder. Sometimes we find it's just, for example, people came across a guy the other day that never ties his shoes, and the reason for it is basically it is too difficult for him to tie his shoes because he's extremely overweight. So he just goes around with the shoes untied. So again, these are things that may give you clues that will open up questions for you to ask that can give you more information and may guide you with regard to if that it can guide you to some potential situations there. This is the things that we find a lot of times that when you go to good clinicians that have been that have used and learned these techniques, that they have good communication skills and good observational skills, that you find these are very excellent clinicians because not only are they making observations rather than simply looking at what's in the medical records that someone else has noted or that the patient has noted, but it does give good insight as to some other things that are going on. We also expect the person to have appropriate grooming and hygiene. We expect them to be clean, well-groomed, nails and hands clean. If we see a change in grooming habits, and that's the key point. The key point here is there a change in grooming habits, okay? So if the change in grooming habits and hygiene, that could be a significant finding, okay? One of the things that we expect is that them taking care of themselves, one, it can give us some insight as to whether they can take care of themselves. If the disease process has progressed to where that either they don't care or that they can or they can't take care of themselves, that's a big issue. And it may indicate that that's a time that we may need to be talking about, some assisted care and things like that. The interpretation of clothing today, and actually it's not been limited today, we do find is you have to keep in mind that this could be a situation with their economic status. It could be their fashion trend. It could be a number of different things. So the interpretation of the clothing is left. You really are interested more, are they appropriately dressed for the season and so forth, versus, I've seen people that have come in these long duster coats. They've come to class, and from one sense, it's 90 degrees outside, but these individuals are wearing these duster coats, and you got to figure out that they're have got to be too hot. It's got to be extremely hot, but they will wear that. We run into co-eds all the time that we see, especially in the summer. is they've got tight jeans on, because we see an increase in urinary tract infections from individuals that are wearing these tight jeans that can cause some inflammation and irritation. So we see those type of things. So what would be abnormal would be just, for example, there's what we call unilateral neglect. So unilateral neglect basically means it seems like on one side of their body they are groomed or seem to be taken care of. At the other side, they're not. And that is not an uncommon thing with stroke, because what happens is the stroke may be unilateral, and their ability to function on one side may make it difficult for them to take care of themselves. So the unilateral neglect is a good sign that should signal us that possibly there is potentially the person has had a stroke. Inappropriate dress, poor hygiene, really just general lack of concern with their appearance. We see this with depression. We see it with Alzheimer's disease. We see it with other things too. But again, depression, they just don't care. And so that's it. On the other hand, if we see somebody very meticulously dressed, often people joke about it, this could be a sign of OCD, obsessive compulsive disorder. This one down here is something that I want you to be aware of, because this is something that we look for. With substance abuse, solvents, inhalants, those type of things, we don't have a drug test for. We really don't drug test for them because it's out of their blood or urine too quick for us to be able to determine it. But if you smell kerosene, gasoline, paint, fingernail polish remover, acetone type things, if the strong smell of these things, or even where that, for example, there may be spray paint on their hands or up around their face or whatever, this might be a good indicator that there may be some inhalant abuse when you put it together with other things. Smoke, obviously, marijuana smoke. One of the reasons why a lot of people do not like to smoke marijuana, there's a lot of reasons why they do, but the downside, many of them will tell you, is the smell of marijuana smoke around their body or sticking to their clothing is a giveaway that they are doing that. So one of the things that we're going to do is that if we smell something unusual, another odor that comes across sometimes is heavy body odor, because with sometimes substance abuse, especially stimulants, they have heavy sweating, and their hygiene is going down. Another smell is sometimes people will describe like meth addicts as having the smell around. There's meth and a couple of others that they describe the smell as cat urine. So unusual smells or things like that may be the situation there. I was wondering if you guys are responding, and I just happened to notice that my chat thing had slid down. So you guys had been responding. I thought maybe you checked out on me this morning, but y'all had been responding. So my apologies there. Some of you with regard to that have worked, sometimes in these institutionals or rehabs, any other odors that you see specifically around with people that may be abusing drugs? What type of odors do you guys, do you pick up on these? That's true, the breath. So the very bad breath, and that's probably with meth, is very poor hygiene. We get the meth mouth. I think I got a picture of that to show you. The burning, acrid smell is their body odor. Monica, you mentioned a chemical smell. That's an interesting. We do see people that they'll describe it as a solvent or a chemical type smell. That's it. Joy, and you just put on there, which is sort of interesting, because a friend of mine who's an attorney has got 3 teenage boys, and was talking about that it has gotten to the point where he and his wife can hardly stand around because of their issue. Carmen, that's a good point too, is that the body odor can also be maybe a cultural issue. I know we have a few students that from their culture that has showed up there. So again, these are some things that we look for. Again, they're not diagnostic, but again, they're important things that come into play that may have a may give us, again, what we're looking for is clues from our observations that may direct questions specifically with this. So I got to tell you guys while I change this next. So we have had nothing but rain here in Georgia. I don't know how many of you have been around in the Southeast, but it's been nasty, rainy, dreary, overlooking. The sun's out, and yesterday was the same way. The sun is out, and so right in front of my office here at my house is I have a bird feeder, and I have two bluebirds that are just like sitting right on the sitting on the bird feeder, just looking at me like, why don't you come outside and play? So this is the first time we've had the winds blowing up a little bit, but the sun is there, and I've got finches and bluebirds going like crazy. This morning when I drove in from church, we have a pair of hawks that live in the lot right next to us. My daughter Allison named them, let's see, what you call them, Lucinda and Larry and Lucinda. I do not know where she got those names up, but as we were pulling into the driveway, one of them just swooped down across the dry riverbed, which was pretty awesome coming up. So, but I've got just a flurry of blue and yellow. I've got some finches and stuff like that are just going to town. So it's been a pretty day. Now, Geraldine, don't tell me we're going to have rain again. Jason, we have not Aiden will take the attendance. And Aiden, did you want to take attendance now? And I'm going to go to the next slide. So I'm looking at this poll, and the answer is yes and oh yes. So what it seems like the class is about 50% is 52% is here, and 48% of you are happy and you have no other thing going on in your life that you'd rather do than be sitting here in front of the lecture. And that just dropped down to 45%. So yeah, Kirsten, I saw that you guys, there was some sort of thing that came up here this week that was talking about whether we wanted 8 or 9 inches of snow, 8 or 9 inches of rain, and the potential flooding versus I forget how much they said in Arizona, but it was a significant amount there. It's there. Does anybody else need to log in here for the attendance? Yeah, Kirsten and Brady, I don't know, when's the last time y'all actually got some snow? Was it, I mean, y'all get a light dusting every now and then, don't you? Yeah, Rebecca, I knew you were moving up there just to catch the snow. And Jordan is rubbing it in. So Eddie, what they're basically doing is they're catching up with all those years of doing that. All right, did you get the, hey, now can you get that? Oh, there it is. I see it. I can close the poll here. Thanks. Got it. Thank you. All right. So this slide here is a good one, and I want you to be aware of this, which translates there will probably be a question about it. So remember, anytime I tell you this is a very good slide or something, that means specifically be aware of it, and you might want to asterisk or whatever. So one of the things is we expect most people to be awake, alert, aware of the stimuli, aware of things going around them, and they respond appropriately to that stimuli. I mean, you know, the point is that Most people in their environment, they're responding and so forth. I mean, if you want to, you sort of people in there when doing things, and this is what you expect them to be, that's normal. But when we start describing people, and we'll see these sometimes when we describe them in the ER, or when we bring them in, or actually when you see them for the first time. So it's important for us to know. So the worst case scenario, let's jump down to the very bottom, is somebody in a coma. And basically, when somebody's in a coma, they're completely unconscious. There's no response to pain. For example, if you take a needle or something and stick them, they don't respond. Various things that there's various different things people have done to use different stimuli to see if people will respond, screaming at them, snapping their fingers, things like that, to try to get them to respond. So we're going at the very worst. So when a person's in a coma, they're pretty much completely unconscious. Most of the people that we're going to see are going to be in the other three, okay? So probably the most common thing we see is somebody comes in and they're lethargic or somnolent. I mean, pretty much not fully alert, seems to drift off to sleep. From a standpoint, even with there's some stimulation, they may drift off to sleep. They can respond to questions appropriately. They can make comments or respond to comments, but what you see is their thinking just seems to be slow, or they describe it as fuzzy. It seems like it takes them a while to have to process it. They're not paying attention, lose the train of thought. Their spontaneous movements decrease. We see this with a lot of, for example, somnolence is one of the symptoms that we see when people have narcotic overdoses. They're sort of this sleepy, lethargic, they can barely stay awake. And, but I mean, it's also, I think most of us have gotten lethargic or somnolent. Go sit in your, when I was in college, between classes, sometimes I was commuting to the college, to my undergraduate, and I would go sit for lunch, go sit in my car. Well, sit in a warm car, and you pretty much just get that drift away into sleep and ignore everything going around you. Sometimes sitting through lectures, you tend to get a little bit somnolent. We usually think of lethargic or somnolent as someone that's pretty much, think about it like when you first wake up in the morning. That would be, sort of that lethargic or somnolent effect there. The next step down, so when we go past somnolence, the person becomes obtunded. And when a person is obtunded, what we see is that they're sleeping most of the time. Very difficult to arouse. I mean, you have to shout at them, shake them very vigorously. When you wake them up, it's like you were in a deep sleep and someone wakes you up immediately. It takes you a moment to sort of, get your wits about you and to find out, to orient yourself and that sort of thing. When you try to have a conversation with them, basically what you're seeing is monosyllables, sort of grunts, those type of things. And if you turn away from them, they just drift right back out to sleep. So they have to be, it's almost like constant stimulation. We see a lot of people that get in after pulling all-nighters or working late shifts or multiple shifts. We see them get in the car and they're actually lethargic or somnolent. Be able to drive. They would basically get in their car and they would be out of it. Okay. The next step is stupor. And what happens here is they really become unconscious. They spontaneously go to a state of unconsciousness. You really got to be persistent, vigorously shake them, use some sort of pain stimulus. And when you do this, basically they pretty much groan or mumble. They can move, but it seems to be more of a restless type thing. Their reflexes are still there. So we look at this as a grade down. Many times, we see people brought in to the ER and they will be described as lethargic or somnolent or obtunded or in stupor. So these are the different terms that we use to really describe the, how people's attention span is or how alert they are. All three of these would not be anybody in these positions in a coma or in a stupor. It'd be highly unlikely they could drive a car, for example. Obtunded would be very difficult to do that. But we do see people that are lethargic or somnolent that may get in a car and try to drive. Then another thing is when this sometimes becomes difficult, and there's some cultural issues that are coming into play here too, is you want to look at their facial expression. And most of you are familiar with this, that what you want is basically that should be appropriate to this to the situation. And it's going to change with the topic. I mean, you may find, for example, take a teenager that is interested, their facial expression is going to be there. Let's say you start going off on a tangent like I do sometimes, the facial expression changes. I mean, you look at the different emojis that they have, and you're going to see those are type of facial expressions that a lot of people have. Eye contact, that should be comfortable or consistent. That should be comfortable, but you have to keep in mind with that it needs to be consistent with cultural norms. Sometimes eye contact can be threatening or disrespectful in some cultures. What you don't want to see is, for example, this mask-like expression. The affect appears to be dull. If someone asks you, how would you, let's say you have a patient that you said, well, they have a dull affect, and you're trying to you're trying to basically describe what this was. How would you describe that? So let's say you examined this teenager, their parents out there, and they said, well, what does this dull affect mean? What do you mean by dull affect? How would you describe that? Okay, expressionless, eyes are downcast, not engaged, non-expressive. Expressiveness or non-expressive, expressionless or non-expressive would be, I think, some good terms that are there. And when you think about it, is they're just sort of like staring out into a void. That's another thing there. And they're not reacting. So, as Carmen, you said, is that you smile at someone. Most people, even if they're, really not happy, they'll at least give some semblance of a thing. So what we find in, so blunted affect, joy, would be what's typically used, or a flat affect, but sometimes I've seen that a dull affect or something like that. But blunted or flat is pretty common what we see. Okay. So, one of the things that, again, this is sort of another thing to be aware of, is that as we start, interacting, especially with individuals, is you're going to be talking with their caretakers. And one of the things that's going to be very important is that their family and caretakers understand basically what you're really getting into. So that they understand what you're saying. It's a lot of times we come out there and we're describing something to the individual, even terms like obtunded, and most people know what lethargic or somnolent means, but, or they'll know what lethargic means. Sometimes they have difficulty with somnolent or obtunded. Most people know what a coma is, and most people, I'd say majority of people know what a stupor is, but their depression of a stupor, or their concept of a stupor, may not be as, it may mean where that they just seem like they're not, responding well, or just seem to be out of it. So sometimes we may have to explain that to these patients or to their caregivers. And sometimes in particular, they may come back and want to know, based upon they're sitting there looking at the medical records, and they come back and have those, have these questions. So we just have to be aware of those, of knowing what these terms mean and how to describe them. All right. All right, so and when you guys answer this, put question 1 and then the answer. So facial twitches and grimaces would most likely suggest depression, hypothyroidism, drug-induced movement. See, now I'm seeing y'all lethargic because some of you put 1C or 1 in the answer, and others just put the answer. And the correct answer is drug-induced movement disorders. That would be the most common thing that you would see with facial twitches and so forth. So you guys did good. All right, let's go to the second question. And again, put question 2 and then answer that one. Sleeping most of the time, difficult to arouse, confused when aroused, requires constant stimulation, describes which? All right, if we go back to the thing here, put this over. So sleeping most of the time, difficult to arouse, confused when aroused, so the correct answer would be obtunded. Okay, good. Okay, so let's go to the next slide. And one of the things about a person's speech is going to, now this is an interesting concept here, because I get a lot of cases that are sent to me to evaluate regarding DUIs. Okay, so typically someone is pulled over and the officer says speech was very slow, speech was slurred, difficulty in forming words. These are things that are there. So one of the things that is important is, if this is the first time you heard the person speak, you may want to talk to other people or ask other people if they have a recording of this person speaking. What we typically want is that the quality of speech is sort of effortless. People talk. There's laryngeal sounds coming out of the voice box. The conversation is appropriate. We're looking at the pace of the conversation is moderate. Stream of talking is sort of fluent. Now, one of the things that and then you see clear and understandable articulation. The ability to choose the words should be appropriate for the education level, that we do see complete sentences, occasional pauses. Now, there are individuals that, for a number of reasons, these may not be. For example, when I go give depositions in the Northeast, they always tell me, "Oh, you're from the South. I expected you to talk real slow." And I always want to just go in there and going, "Well, howdy, y'all. What you call it? Let's just go." I'd sort of go in those type of things there. But again, one of the things is there's different people that speak. I think about the people that I know around me that I consider, normal, that I see, fairly frequently and things like that. And so what I expect is, some of them speech may be a little bit slower. I do know some individuals, as they get older, I do it myself. Sometimes what will happen is that you'll pick up a word or you'll have in your mind a word. Or another thing that may happen is sometimes if I'm giving a lecture and I look down and I see a word and I read it and pronounce it just the way it's spelled, which may be, for example, I gave a whole lecture on a drug called dilithium. And because I picked up, and then once I started saying it, just kept going over. And the students were asking me what was this drug, and it was actually diltiazem, which was actually a calcium channel blocker. So the point becomes is you really need, in many cases, a point of reference when you're looking at speech. Some things are pretty abnormal, and you would see this. So if we see people, some abnormal type things that would be an abnormal pitch or volume. I may give you guys, if I can find some recordings of this, I may give you some examples when you break for lunch. I think I do have some recordings which you can hear some different speech patterns. And if you're not aware of those, we'll get those maybe where you can listen to them at lunch. Slow, monotonous tones. I had a couple of friends that have had Parkinsonism, and their speech, which used to be very lively, there's a big difference, and they talk very slowly, and it's very monotone. Depression, I've seen people with depression do that also. Rapid, very pressured, I'm talking about almost can't get the words out fast enough. And loud, we see that in mania. I see that in drunks too. I had to get the manager to stop serving a lady at the Outback restaurant a few weeks ago because of the loud and rapid speech pattern, which in a matter of 40 minutes, she had equivalent to about 10 drinks, and you could see the whole thing progress, where her tone was, she'd already been drinking a beer when I got there, and in the 40 minutes, her tone had gone up quite a bit. Distorted speech we refer to as dysarthria, misuse of words, omission of letters, syllables of words or transposing words. This is aphasia. And long periods of trying to find the right word or can't find the right word. This is referred to as aphasia. So what we'll do is we will give you at lunch access to some recordings that I think I can pull those up that you guys can listen to so that you can see what this is. Okay? All right. So I think, let me see where we're at here. Yeah, this is a perfect place to take a break. So let's come back at 15 after the hour. And we're going to then talk about some signs and symptoms of substance abuse. Okay? All right, so we'll return back at 15 after the hour. Show you those speech patterns there if you're not familiar with them. So we'll put those up for lunch so you guys will know that or have that. And let's get back to, so the next group is, we touched a little bit about these that deal with alcohol and substance abuse. When I gave you the lab test, I think the first week of this class, basically, I showed you there was some signs and symptoms which were not diagnostic. So there are some things that we want to look at here from a standpoint of assessment. And surprisingly, we have, or I have had experience over the last several years where that the individuals basically show up in the ER and their blood alcohol was very, very high. And what we actually see was that that in the ER, there was no notation of them being drunk or, whatever. And so the explanation is how can that occur? So I'm going to come back to that in just a minute and point out a couple of things to you there with regard to that. But from a standpoint of, let's look at the substance with alcohol, which is, very commonly abused, and you may deal with patients that are there. What most people, when you think about, as they describe someone who is under the influence of alcohol, a lot of times they will talk about, well, the person was staggering, so unsteady gait, or incoordinated, seemed to have difficulty, doing certain things. Nystagmus they may not have noted that, but the nystagmus is the vibrating of the eyeballs. Many times they'll describe them as a flushed face, because alcohol does cause vasodilation of the blood vessels. And so a lot of times when people are drinking, you see them. The other thing that we'll see that people will describe many times is their eyes look bloodshot or glassy, which the alcohol can produce that type of effect. So during intoxication, typically, so for example, I get called about a lot of what is called dram shop cases, and where that the person is suing a bar because, or a minute market, based upon the fact that the individual at the blood alcohol should have known that the individual was intoxicated. So, a lot of things around here, the bars and everything, that the people go through the training of how to recognize when someone's intoxicated. And the idea is that if they're intoxicated, you're not supposed to sell liquor to them or alcohol to them. And typically what I've seen over the years is the takeaway things are that bare minimum is that if the individual has to give you a valid ID, presenting the valid ID also implies that the individual is able to pull it out of their wallet, hand it to you, understand your instructions. That's usually not a big issue. But then they also sell, if there's a smell of alcohol on them, not to sell to them, and any signs of intoxication, where they staggering, where their eyes glassy, and so forth. So those are the typical things. And one of the things that comes into play here is that a lot of individuals, even trained individuals, and there's been studies on this, that even with trained individuals, that someone can have a fairly high or have an intoxicated level of alcohol that may not be detected. And in fact, one study that gets cited a lot says that if the blood alcohol has to be around a 0.135 or higher before the majority of people can detect that individual. What do you think is, why was this not being, why does it take that much of blood alcohol? In other words, somebody could be at a 0.1, which is, over the legal limit in every state here, but could be a 0.1 or 0.1, 105 or 0.11, and still somebody say, well, I didn't notice it. What would you think the reason for that? All right, that's one of the things is tolerance. And that's probably the big one, is because we do see people, doesn't mean that when somebody is tolerant that basically they're not impaired, they may not act impaired. That's the key point, is that outwardly they may not be expressing that. What's another reason that someone may not have pick up on a 0.35? That's a good one, is that in an area where there's a lot of drinking, is that someone at a 0.135 may seem to be acting normal. Okay. You think any other reason? Maybe just the type of the interaction. So for example, if you walked into the hospital room and you were supposed to assess somebody, and they were laying in bed, and the point would be is that you would not necessarily have any opportunity to see them try to walk or have them try to do certain things. So, that may be another issue. I mean, there's been people that have gone in bars. I've talked to people. I've got friends that are bartenders and so forth, and they'll say that most of the conversation they have had with some people are like, hit me again, or just what they want, and very little conversation whatsoever. So it's hard for them to tell when somebody says, whiskey, or somebody says, PBR. It's hard to say that they're slurring their words. They're not having a long conversation with them. But other things that we may see are down on here. We may see, for example, sedation. Sedation is, they're pretty much going to be out of it, where they're sort of passed out. Dulled concentration, they're not able to think clearly. Impaired judgment, uninhibited behavior. One of the big things that we see is, depending on the individual and the environment, is that an individual may drink in some instances. For example, if the individual is drinking by themselves, one of the things that may be happening is that the individual is drinking by themselves, may be very introverted, may be withdrawn. On the other hand, if they're at a very loud place and boisterous and so forth, a loud environment, they may become very boisterous and so forth. So they could have uninhibited behavior. I find it sometimes is that a lot of students are unaware that alcohol is a CNS depressant. They sometimes think of it as a CNS excitatory, because they, basically see people that seem to be, talking loudly, basically uninhibited, impaired judgment, being very extroverted and things like that. We have impaired memory, which includes blackouts. One of the things we do, we have blackouts and brownouts. Have you guys heard both of those terms when it comes to alcohol and substance abuse? Okay. So, all right. So most of the people have heard blackout. And then when we're talking to the lay public, one of the things that we have to explain to them is a blackout is not passing out. That is a big misconception. So some people think that they blacked out, they passed out. The blackout is where that they have periods that they don't have any memory of what they did. The brownout is what we refer to it sometimes is that they remember certain things, but not everything. So a blackout, they don't remember anything, and a brownout is they remember some things, but not everything. Is that the way you guys have heard the term brownout sort of described? Yeah. So, in fact, I get called in on some rape cases, and one of the things is that this has been an interesting situation that we've seen occur is that people have sued some of the dating apps, stating that it put them at risk, and the individuals, like I had one case where the person had probably drank, I don't know, the blood alcohol was well above the almost twice the legal limit. And the girl said she, left, that the guy had slipped something in her drink, and they had all this stuff. They had toxicologists actually came in, and the girl had actually left under her own power. The guy did not route. They ended up a little bit later on. And so she was claiming that he date raped her and slipped something into her drink and so forth. But we had videos all through where she was going through the parking garage. And if anything, she was in a blackout, which has now created another scenario we've started seeing pop up, which is if someone is in a blackout and gives consent, or if someone is blackout and has sex, is that were they able to give legal consent? And the issue becomes, would the person that the partner know, or the sexual encounter with the guy or the girl know that the person was in a blackout? And so that's created another big issue there. But we see a whole, as you can see with alcohol intoxication, we see a whole gamut of things that occur. Depends on how fast they drink, depends on how often they drink, what their tolerance is. So a lot of that is important in determining how they would react to the alcohol, the environment they're drinking in. We do see sometimes some people drink one type of alcohol and respond a certain way, whereas they drink another type of alcohol and respond entirely different. So we've seen that there too. But also the other thing we do see is that when people are chronic drinkers or even alcoholics, then basically we can see withdrawal. And I've told you guys before, but the one withdrawal that can be life-threatening is alcohol. The other withdrawals, people think they're going to die, but unless there's some underlying physical thing, they usually will make it through it. So during withdrawal from alcohol, most of you are familiar with this. We see tremors, hand tremors, the nausea, vomiting, general malaise, heart rate goes up, they start sweating, blood pressure goes up, they may complain of headaches. In fact, some people believe that hangovers are a form of withdrawal. They can't sleep, they get very anxious, can get depressed, become very irritable, even have hallucinations. Our big concern is if they go into the DTs, delirium tremens. And delirium tremens, basically, what we have here is they develop tremor, heart rate goes up, sweating, very vivid hallucinations, delusions, agitated behavior, and fever. And one of the concerns is they can go into seizures. And there's like 4 different stages of DTs. I think Dr. Norton is going to go into detail about alcohol and some of these other drugs as far as their effects and withdrawals and stuff like that. So I'll let him go into that and cover that. But we really don't want the individuals. In fact, we do see sometimes we have had instances where a physician has actually prescribed a beer. I've had at least 2 of my pharmacists on separate occasions come to me to ask me about that they dispensed Pabst Blue Ribbon. And it was because it was an individual that was in the hospital that was a chronic drinker, and they didn't want him going into them going into withdrawals, alcohol withdrawal. And the old thing that you used to see on the TVs, where in the movies, where you'd get the town drunk and throw him in the basically in jail and let him sober till he sobered up. We don't see that throwing somebody in there and letting them go through withdrawal, especially if they're a heavy drinker, could potentially be a life-threatening scenario. The sedative and hypnotics, here we're talking about primarily the benzodiazepines. We're talking about, this includes also the Ambiens, the barbiturates, and so forth. Their effects are very similar to alcohol. And the reason for that is they act on a very similar receptors. And in fact, one of the things that we see is that with the benzodiazepines, we frequently, in fact, a guy that used to teach my class, my abused drugs class, used to say that doctors, he was a recovering alcoholic, and he said doctors thought for a long time that their discovery that the cause of alcoholism was a benzodiazepine deficiency. He said because what he used to see was anytime alcoholics came in, the doctors would just give them a prescription for benzodiazepines. So what you were doing is you're not drinking, but you're getting the same type of effect. And in fact, what we do when alcoholics is a lot of times we're going to put them on a benzodiazepine and then taper the benzodiazepine down. So the intoxication is very similar that we see with alcohol. One of the things that we do see many times is that people will combine alcohol and these sedatives. And we've had, for example, a lot of people died with barbiturates and alcohol. And that was one of the reasons the benzodiazepines were brought to the forefront, is they thought that they were safe. But we have had people that have died from a combination of benzodiazepines and alcohol. And just one other thing is something that's been coming out, which is sort of interesting, is that there's been some papers that have started to emerge now that we've had such a focus on the opioids that they're talking about that doctors have been watching what they've been prescribed as far as opioids, but we've actually have under the surface epidemic of benzodiazepine epidemic, simply because there's been a lot more benzodiazepines that are being prescribed. When the individuals are coming off of it or going through withdrawal, we can see anxiety, irritability, general malaise, nausea, vomiting, heart rate goes up, sweating. Orthostatic hypotension means when they stand up. You guys know what orthostatic is. Basically, they stand up too quickly or change position. Their blood pressure drops down. Seizures can occur, even though these drugs are used to treat seizures, but during withdrawal, the seizures can occur. Again, the withdrawal is not quite as bad as alcohol, as life-threatening, but is pretty unpleasant. Nicotine, going to the next slide. Nicotine is basically one of the most abused drugs. What I like to tell people is what I learned several years ago in a seminar that I went to that was actually taught by the dentist, the former dentist that treated the Marlboro man. He used this example, and I think it's, if you wonder how addicting nicotine is, if a person smokes a pack per day, basically there is 20 cigarettes in a pack, and they have watched, and the typical mean number of puffs per cigarette is 10. So he said, so a person smoking a pack a day literally is getting 200 hits of nicotine. And if you think about, there is probably no other drug that is abused at that quantity, if you will. But what you find is when people are, on nicotine, whether they're smoking, chewing, or whatever, they tend to be more alert. We know their blood pressure goes up, particularly their systolic blood pressure. We know their heart rate goes up. We know their blood pressure goes up partly because of the vasoconstriction. And that's one of the things we're concerned about, is the vasoconstriction, especially the heart blood vessels. At higher concentrations, people working in the tobacco fields a lot of times would be exposed to high concentrations of nicotine, and they developed nausea and vomiting, loss of appetite. In fact, a lot of people, when they're smoking, they lose weight. When they stop smoking, they gain weight. The nicotine tends to suppress appetite, plus the smoking dulls the taste buds, which are, and also tends to decrease gastric secretion or increase gastric secretion. So that can occur, but we see people get sort of dizzy, can have some dizziness, jitteriness, mild stimulation. Most people that are smoking will say it sort of alerts them, picks them up. But when they go through it, I think most of us have been around probably some people that have smoked, and they can't get to their cigarette break. So what happens is the blood pressure drops because the blood vessels vasodilate during withdrawal. They have headaches, they get angry, they get irritable, they wake up at night. In fact, part of the reasons they wake up at night is people think they're going through withdrawal. A lot of people will tell you the cigarette in the morning is the most satisfying, and that's because they've had several hours where they haven't smoked. One of the big concerns we had years ago was people smoking in bed. And when they smoked in bed, they'd fall asleep, and guess what? Catch the bed on fire. So it's been one of those things that's come up there. They get nervous, they get can't concentrate, can go into depression, get hungry, restless. Just think about when you see people that are sort of going through that short nicotine withdrawal. There are a lot of people describe that they're very difficult to be around. Marijuana is a new thing. You're right, Angela. A lot of people are surprised that nicotine is actually a stimulant because it does say it relaxes. They think it's not a depressant, and so that's one of the things that's interesting. What I used to describe it sometimes, the way that you can have it is like sometimes you can get a stimulant effect from depressing the depressant actions, which makes the stimulant goes out. And sometimes you can get a depressant effect by depressing the stimulant or enhancing the depressant actions. So that's the way with that. Marijuana is taking on a whole new thing. In fact, I've got to go give a talk to the Alabama Coroners and Medical Association next Saturday dealing with medical marijuana. What we do know is that when people smoke, they get bloodshot eyes. That's one of the big things if they're smoking. Of course, if they're eating the marijuana, that's not it. Tachycardia, their heart rate goes up. Mouth gets dry. They get the munchies. They get the euphoria. They can have changes in perceptions. Their judgment can be impaired. They can withdraw socially. They can develop paranoia. These are all things that have been identified with. And one of the things that is coming up has been the issue with the medical marijuana with regard to whether people actually get addicted to marijuana. And we've actually, many people get medical use or marijuana use disorder, which can move to addiction. And so we do see, and the statistics show about 101 statistic says about 135,000 to 150,000 people probably go in for marijuana addiction or marijuana use disorder for treatment alone. So there is an addicting quantity to it. One of the things that you need to be aware of, I could do a whole hour on this, but if not longer, but with the CBD, the cannabidiol stuff coming out, one of the things that you need to be aware of is there's a lot of places that are selling CBD, and CBD doesn't produce the euphoria. But here's the thing, and this is even with the prescription medications. If it is the new drug that was recently released, Epidiolex, which was released for treatment of some forms of seizures, just came out a few weeks ago. I just talked to the drug rep, and one of the things is that is a plant-derived drug. And one of the things that you need to be aware of for your clients, patients, is that with CBD oils, we are seeing that if it's extracted from the plants, which almost all of it is that I'm aware of, the CBD oils cannot be extracted completely free of THC. So one of the things that may happen is that the people taking these CBD oils, and we've actually already seen it occur, that they have tested positive for THC because THC is there. So that's one of the things that needs to occur. Now, as far as withdrawal from marijuana, we don't have as much data. A lot of people use multiple drugs. There's a lot of different things that are coming in there. And so one of the things that you see is basically it's very difficult to identify withdrawal symptoms, but you would anticipate very similar to what we see here. So that would be one of the things that is I mean, we'd see the restless, irritability, the sweats, and so forth. We would see that also. All right. So we're going to do this. Let's see. Yeah, we're going to do this slide, and then we'll take our last break for this morning, and then we'll come back and do a little bit more, and then I've got you guys. We'll do some. Then I've got a couple things for you guys to do at lunch, and we'll pick back up on this. All right. So other drugs, I have not included all the drugs there. I've just hit the high points here. So cocaine, it's a stimulant. See, any stimulant is going to produce pupillary constriction. We're going to see, typically we see heart rate going up with cocaine, but it can go down. But typically it's tachycardia. Blood pressure goes up or down. Typically it goes up. Our biggest concern is increased heart rate and increased blood pressure, which can lead to some strokes and things like that. They may sweat from the stimulant. They may have some nausea, vomiting, weight loss, euphoria. They become stimulated, more talkative, hypervigilant, may be pacing around, can easily get agitated, become more aggressive, have ideas of grandiosity. They develop the cocaine bugs. These are this is where they have hallucinations, thinking that there's bugs or worms crawling underneath their skin. These are so real, they'll sometimes take a knife or even take their hand or their fingernails and try to claw through the skin to let them out. What we see is that the drugs like cocaine hydrochloride, which is what you typically see somebody snorting, is at higher doses of cocaine, you tend to see more aggressiveness and more irritability and so forth. We tend to see more of that in people doing crack or doing freebasing. And the other thing we find is, so they get this stimulant effect, which can be the grandiosity, the aggressiveness, but on the withdrawal side, they can get a lot of dysphoria, basically anxiety, depression. One of the big things, I didn't have it listed here, we see a lot of paranoia with the stimulants. Get very irritable, insomnia, can't sleep, get very, very agitated. That eventually goes to the point where they become that they're overly sleepy and very hungry. So everything you see that suppresses appetite and stimulates them, when they're coming down, we see just basically the opposite. And amphetamines, and we would include methamphetamine here also, which we see probably more use of. Well, let me put it to you like this. We will see the amphetamines like Adderall abused more in the college age group, high school age group, but that also would include, they're not amphetamines, but they're related. But you would see something like methylphenidate, Provigil, Vyvanse, those type of drugs. Those are all stimulants. We see euphoria, elation, agitation, erotomania. We see more of that coming in. A lot of paranoia. We see the dysphoric mood when they come down, fatigue, can't sleep while they're on the drug. When they come off the drug, they can't sleep because they're so restless, and then they go into where they're hypersomnic, where there's some hypersomnia. They just can't hardly wake them up. We see with meth, it's interesting with cocaine. One of the reasons people moved away from cocaine was primarily because of it. They were afraid of getting addicted. And over the years, we've seen when cocaine use was up, amphetamine use was down. And in fact, a lot of people moved to cocaine years ago because they were getting addicted to amphetamines. You could actually buy amphetamines over the counter back in the 30s, I think, and even into the 40s. So a lot of people were using amphetamines to lose weight. They were afraid of getting addiction was a concern, so they switched to cocaine, even though we have all the data that shows cocaine is as addicting. So now what we have is we have both cocaine and methamphetamine and the amphetamine-like drugs. All of them are stimulants. All of them produce the increased blood pressure, increased heart rate typically. And that's it. Rebecca, you just made a comment. There is the CBD oil is all over the place. I was went out to dinner last night, and there was a new sign up that says a new CBD oil place that opened here in Athens, and it was offered free samples. And it's all over the internet. And supposedly the CBD oil, I mean, the CBD oil theoretically doesn't have, it actually antagonizes some of the stuff associated. I mean, some of the you don't produce the euphoria, and it antagonizes the negative effects of the THC. So most of our new the drugs that we have out that are medical marijuana are supposedly have about 50% THC and 50% CBD. The THC will stimulate appetite, so CBD doesn't. So when you're using this for a wasting disease, you want the THC. So again, pupillary constriction is a big issue with the cocaine and stimulants, and with the opiates, or a lot of times. One of the things I'll tell you is sometimes the police will describe narcotics. They will include narcotics as all illegal drugs, and that's not the case. So narcotics, we usually think of those that produce narcosis, which is typically the opioids or the opiates. What they will produce is they produce meiosis, pupil constriction. That's one of they don't develop a tolerance to that. Blood pressure goes down, heart rate goes down, their body temperature goes down, they become very lethargic. The opiate triad basically is the thing when somebody comes into the ER. Does anybody know what the opiate triad is? It's the three symptoms that we see with somebody in opiate overdose. They're lethargic or somnolent. We find their pupils are constricted and their respiration is depressed. So that's the opiate triad. Those, if somebody comes in with those, they're going to use naloxone to immediately do that. If any of you are treating patients that are opiate addicts or that are abusing opiates, you might want to seriously think about getting naloxone and having that available, in your practice or in your office. There is a discussion about whether that would be, whether that when a prescription for narcotics is prescribed, that naloxone should have to be given at the same time. What typically people do is they will have an initial euphoria, and then they come back to sort of a dysphoric, sort of apathetic state. Psychomotor retardation is pretty common. Can't stay focused on anything, forget things, have impaired judgment. When they go through opiate withdrawal, again, we see many of the opposite. Instead of meiosis, we get mydriasis. The pupils dilate. We see a lot of times they are their tear ducts are running. It's not they're crying. It's just that their tear ducts seem to be, they're lacrimating. So a lot of tears and their eyes are very watery. Typically a runny nose, heart rate goes up. A lot of them develop fever, blood pressure goes up. The hairs on their arms and legs will tend to be sort of erect. We call that a piloerection. They'll sweat, a lot of times sweat pretty profusely. They a lot of times will have some diarrhea. Frequently they're yawning a lot and can't sleep, get very restless, very irritable. A lot of patients will describe the effects that they see during withdrawal, similar to having a bad case of the flu. So this is a big concern because of the overuse of narcotics. And so it's one thing that we look for quite a bit. And a big thing, if any of y'all are treating patients, is a lot of heroin addicts. One of the things we've been seeing is fentanyl being substituted for heroin on the street. So the person thinks they're buying heroin. And fentanyl and some of the fentanyl analogs, these are derivatives of fentanyl, can be extremely potent. And not only are they potent, but a lot of times it takes a lot more naloxone. I know a couple of the hospitals on weekends will sometimes tell the ER docs, we have only this much naloxone. So you need to be careful when you use it because that's all we have. All right. Let's come back on the hour. This will be our last break this morning. We're going to shift topics, so we'll talk about body mass index and a couple of other things. And so let's come back on the hour. Aiden, I'm going to send you a couple of things to post. I don't flip through a couple of slides, people, so don't worry about if the slides are moving. but we'll start back on the hour, and we'll go for about 30 minutes. Then I'll have something for you guys to do at lunch, so you have a little bit long. Okay. We'll see if we can post that on there too. Appreciate you passing that on. Okay, so let's go ahead and talk about. We'll move away from the drugs for a little bit. Again, you're going to get Dr. Merrill Norton will be giving you an entirely different an entire lecture on the weekend with lugs and with drugs, and I think I'm having some speech problems here. So he'll go into great detail about addiction and so forth. So I think that'll be a good thing for y'all. So one of the things that comes into play, and again, some of this stuff you will see we will cover. So what I'm going to try to cover before lunch is we're going to talk about weight. We're going to talk a little bit about some things, and probably try to get through the pain before we go to lunch, to talk about just a little bit about pain, because you will also have electro and chronic pain, which I will either teach or another faculty member. Depends on whose schedule works out better for that. So one of the big things we see here is body mass index, BMI. And so be prepared that I could give you and ask you to convert to a BMI. So we will use, rarely do we dose drugs for weight, but we do use BMI. And there are some problems with BMI because, even some athletes who would be considered, I think from a standpoint of their body, you would say that I wish my body looked like theirs. They would actually be, according to the BMI, would be obese. So it's an indicator of obesity. The other thing that we use for measuring body fat is we would use calipers to measure body fat, which are not as accurate. Probably the best way to get an idea of the amount of body fat is going to be using these submersible pods. They sort of are, you basically get in them and they measure water displacement. There are scales out that you can buy, at Bed Bath & Beyond and some other places online that will give you an estimate of your percent fat. But the BMI is what we typically use, and so you take the weight, your person's weight, and what you do is you convert that to kilograms. And the way you convert to kilograms is basically 1 pound equals, or 1 kilogram equals 2.2 pounds. And so, for example, if someone weighs, 100 pounds, then you just simply divide that by 2.2. And so that person would basically weigh 45 kilograms. So you take the weight in kilograms and divide it by their height, then you convert that to meters squared. And that will give you that actually gives you the BMI. I'm double checking to see if somebody, okay. So, if I gave you this, the question you would have would be, based upon a person that weighed so many pounds and I wouldn't have you do a conversion on height. I just give you the height in meters. Basically, you would convert. I would ask you, would this person be underweight, normal, overweight, obese, or extreme obesity? Typically, what we're looking at is someone is considered obese if their BMI is 30 or above. There has been some debates that have kicked in with regard to that. America in particular is getting when the person is getting as America is getting heavier, there's a consideration that maybe we ought to move this scale up. So that has been one of the concerns that's there. So BMI is typically calculated, and we see that used. And again, a lot of individuals like general practitioner would be wanting to use that. Where you would be particularly concerned about with the BMI would be maybe if you're dealing with eating disorders, but with a group of drugs that you prescribed, the antipsychotics would be a big concern, specifically with regard to that. Okay. So again, it's rarely do we dose by weight. And there are some times that we do, but typically most drugs we're not going to dose that way. Okay. Now, The BMI is basically, a lot of times they'll just use it. Let me go back. That's a good question there. A lot of times, I mean, there's actually units which would be kilograms per um, meter squared would be the actual units, but a lot of times they just put the BMI and put the number, so they don't actually put it in kilograms. But it is you have to calculate it in kilograms for it to be correct. But when they list it, they just put a BMI index. They'll just simply put as a number there. But in reality, it would be kilograms. BMI would be kilograms per meter squared would be the actual units, but most people don't use it. Exactly, Joy. There is a lot of apps that are that use to calculate that, and they also, in fact, if you want to be, sometimes a little bit depressed, is have them calculate your ideal body weight. But you're right. There is we see a lot of apps that are coming out that will do that, and a lot of the nutritional apps will say, okay, here's what your BMI is, and this is what your ideal body weight, which figures in what it should be for your height and age. Keep in mind, as you get older, the point becomes is you're going to have more body fat. And so a lot of people are, we have athletes, some of our athletes, football players, for example, their percent body fat is single digits. And but from a standpoint of most people are not going to get down to that. And you're very right. The BMI may not be the good indicator of how healthy the person is. In fact, there's this thing called what is it? Let's see, what's the term they use? I think it's fit fat, which means some individuals that are overweight that would be considered fat. We don't use the term somebody being fat anymore. We talk about them being obese. But there are some people that are overweight that basically would be more fit, physically fit, than other people that are at their ideal BMI. And Joy, your BMI is the parameter that's used, but there are a lot of limitations on what it is, and it is not a good accurate indicator of health. There's a lot of people that, again, that have an ideal body mass index that would be out of breath walking to the bathroom. So it is not, but that is one parameter that is used, and they will track BMI, for example, or at least body weight when people are put on antipsychotic drugs to make sure that they're not gaining weight, which can happen with the antipsychotics. All right. Now, we have touched on pulse oximetry before. I want to reemphasize this. You know that it assesses oxygen saturation. It's an indirect assessment of that. We put it on the finger. Most people put it on the finger. But one thing that's important is the earlobe is actually probably more accurate site. You are more likely, and the reason for it is this last point on this slide, is that your blood vessels are more likely to get cold or whatever, peripheral vasoconstrict from your fingers than your earlobe. So typically what we're going to see as a healthy person is 97 to 98%. And what this is doing is the oximeter, the pulse oximeter, is basically measuring, it's a photosensor, and it's measuring the amount of light that's absorbed by the oxyhemoglobin complex and the unoxygenated hemoglobin. So the person that their oximetry goes down to the low 90s would be someone that may have some respiratory issues. And if it's in the 80s, we see smokers and stuff like that, it's 80s. But normal healthy person their oximetry should be around 97 to 98. And again, this is one of those, you may or may not choose to measure this. And it's just really up to if you want to get that parameter or not. If you have somebody that has respiratory problems, it may be worth measuring it, but you at least need to know what it is, because it is an important thing. And one of the things that may come into play is some of the mental issues that a person may experiencing could very well be due to the low oxygen getting to the brain. Just to pick up on something, Joy, you put on the chat board, is a lot of times as we're doing physical fit, they want you to chart things. We do know that people that keep a diary of their food intake actually do better and have greater loss of weight. But people like to, especially with the apps and stuff like that, they like to do the BMI. What I tell people a lot of times is I tell them that probably one of the best index as far as your weight goes is called is whether your clothes fit or not. My dad was always a small person until right before he died, a little pot belly on him. And when his pants started getting tight, he always blamed it on my mom leaving his pants in the dryer too long, so they shrunk. I called it the dryer factor. But a lot of times is that, you know, you can tell whether you're losing weight basically by the way your clothes fit. I mean, if your clothes start getting tighter, obviously you're gaining weight, and sometimes it may not be reflected in a BMI or whatever. A lot of times the BMI doesn't give us an idea where the fat's actually being, you know, deposited and things like that. So what I want to try to cover before we break for lunch is dealing with pain. And again, we're not going to go into great deals with pain. I know that Dr. Davis covered this a little bit, and it is something that you need to assess when somebody comes in. But I want to sort of go over some different types of pain and and give you an idea of what to be thinking back. So one type of pain is called neuropathic pain. Okay. So what neuropathic pain is it's there is a problem where your body, it has a abnormal processing of the pain. Okay. It's very difficult to identify. The pain seems to be sustained on the neurochemical level. In other words, transmitters are seeming to keep the pain. Pain we cannot detect by imaging. For example, if we do a we can find an abnormal structure which would be impinging on a nerve, and that would tell us that that's where the pain occurs. We may see an area on some imaging that shows inflammation, but it doesn't really give us pain. But what we do a lot of times is we will use electromyography and nerve conduction. So what we're looking at is to see if these nerves are firing abnormally. And if they're firing abnormally, a lot of times that results in pain. The big thing about neuropathic pain is somebody gets injured and the pain seems to persist. The injury is healed, and theoretically there should not be a pain, but the pain just keeps on hanging on there. And so that's why we refer to it as neuropathic pain. We think the mechanism is that the nerves get actually hurt, and these nerves start spontaneously firing. And not only do they spontaneously fire, but they sort of become repetitive. So it's almost like the nerve is having a seizure. The nerve is seizuring in a way. The pain, they describe it is being sort of sustained because they describe what is known as a neuronal windup. You have actually nerves in the dorsal horn of the spinal cord. They become hyperexcitable. And so what happens is that it doesn't take very much stimulus for these nerves to start firing at a high rate. So that's sort of the wind-up thing. And so what happens is it takes just a little bit of a stimulus to get these nerves are sort of wound tight and they're ready to fire. And so just a little bit of stimulus makes them go off. So we find that this neuropathic pain can be a real thing. We find that it is very painful for these individuals, and it can definitely affect their quality of life. That's one of the reasons we're using drugs like gabapentin. Those drugs seem to can interfere with that. But neuropathic pain is one type of pain. Let's look at a couple of other types. Visceral pain comes from the viscera, so basically the larger internal organs. Typically, the organ is either directly traumatized or injured, or it can be due to stretching of the organ. So things that when, like for example, the stomach is hyperextended or the intestines become hyperextended. What happens is that the pain, some forms of torture people would take, for example, pass down into people's and fill their stomach till it's hyperextended, and it would be very painful. Then they would, punch them, which would add to it. But what happens is the pain impulse actually travels along the nerve fibers that run right next to the autonomic nervous system, which also comes into play with regard to why that a lot of this visceral pain is associated with vomiting, nausea. They get very white, have some sweating. This is all autonomic nervous system things. So visceral comes from the visceral organs, typically the larger organs. The deep somatic pain, when we talk about the somatic nervous system, we're talking about really musculoskeletal. Most of the times this is coming from the joints, the tendons, the muscle, the bones, or even the blood vessels associated with it. And a lot of times this deep somatic pain is due to either pressure being put upon that. For example, it could be a bone spur that's pushing down on a nerve. It could be swelling that is pushing on there. Can become ischemia. So, for example, the area is not getting enough blood flow. And so this can be very, these can be these aches and pains that people have. So one of the things, for example, that can happen is that, let's say, you've got some arthritis in your knee and you go out and work a lot. Well, the increased working causes more inflammation and trauma to the knee. And so when you come in, your knee hurts for the next couple of days. One of the things that we commonly see is that individuals, when they get real tense, the muscles in the shoulders and the neck, you have a lot of nerves running down there, and those nerves, when those muscles constrict, that pushes down on those nerves and causes some ischemia and pressure, and that can hurt. So these are the really musculoskeletal type pain is what we see with somatic pain. Cutaneous pain is primarily from the skin or just underneath the skin. Typically, these are the superficial injuries. You scrape your knee, you basically cut your hand or something like that. If you think about that pain, is the pain that you see like when you cut yourself, that tends to be, or burn, tends to be a sharp burning sensation, whereas the somatic pain tends to be more of a dull, aching type pain. And then another type of pain we have, which is really difficult to deal with, is referred pain. So what happens with referred pain is basically, I think all of you have probably experienced it, where that you hurt one area. So what happens is the pain is actually felt at some site that's different from originated at, okay? What we believe is both of these sites are innervated by the same spinal nerve. The brain just can't differentiate where the pain is coming from. And I'll show you on this next figure. So for example, let's use heart pain, for example. So one of the things that we see, if you look at the heart here, is that, so if you look at the heart, basically when people are having a heart attack, one of the things that you see is on the left side of this figure, you can see that typically we say that the heart, when somebody's having a heart attack, we see the pain that's coming down the left side. So the pain is referred down there. The back, in the middle of the back is another area. People that have gallbladder or liver pain, well, of course, the liver is here in this area on the left when you're looking at it, but these people may also have pain up here in the neck region. They may also have pain actually out their back. Urinary bladder pain is, we see that where the urinary bladder is, but that can also be to the back here, and even down on the into the groin areas. So these are where the pain is referred, and so these sometimes, what hurts the worst may be the most difficult part. So typically, notice the appendix, we see it tends to be right here, but we don't see it referred very often, to bigger areas. But the heart is a good example, but there are some examples where the pain may be felt, and where this pain is, for example, the stomach. People think about the stomach in the front, but you can also have it in the mid portion of the back here. So this is referred pain. Now another type of, so let's go to a question. We're going to get these, we got two questions back to back. So this is question number 3. If you'll put question number 3 and put your answer. So stimulants produce A, meiosis, or B, mydriasis. Okay, so the answer is B, mydriasis. That's the pupillary dilation. And let's see, let's go to the next question. Question 4. So dysphonia is going to be difficulty hearing, distorted speech, abnormal volume, pitch, or speech. And dysphonia is going to be, should be C. Okay. All right. All right, let's move back and let's try to cover, let's see, a few more slides before I let you guys go for, yeah. All right, so the other thing with pain is we classify pain as far as when it occurs. So if it's acute, we consider this short-term and self-limiting. Acute's going to be basically what's going to happen. You stub your toe, you cut yourself. Pretty much it hurts. When it heals, pretty much you have no more pain there. Basically, this is our protective mechanism. It's sort of like warning us of potential tissue damage. We need to move back, so we burn our hand on the stove, we let the hot pan go, those type of things. Typically, this is going to be, again, very self-limiting, is not going to affect people a whole lot. It's going to be more and more of a situation where that, yes, the person may not be able to do something for a short period of time, but can resume activities there. Our biggest issue is, our more pressing thing is chronic pain. We define chronic pain as lasting more than 6 months. The injury is, the basic injury is healed, but the pain keeps hanging on. And the other thing we see is that the level of the pain doesn't really correspond with the physical findings. And the reason that goes is because, again, the physical findings a lot of times, now we do have situations like, for example, arthritis, is that we know that there is constant irritation and inflammation that's occurring. But chronic pain is hard to manage because it affects quality of life. The medications that we have for it, having to be taken chronically, create more and more of an issue there. And so opioids, we're looking for new non-opioid type things. In fact, a lot of people think chronic pain has pretty much created the opioid epidemic. There's another term that's an archaic term, but I want to put it out because it pops up every now and then. This is called psychogenic pain. And the original definition was that it was pain without a known physical cause. Okay. That was assumed when this term was used, it was assumed that this was either due to some sort of psychiatric or emotional issue. The American or International Association for the Study of Pain now considers this an obsolete term. A lot of the psychogenic pain was actually now defined as chronic pain now. And sometimes we see neuropathic pain mislabeled as psychogenic, but we don't like to use that term because it really doesn't fit. There's no real basis for that. Now, an important thing to do is to be aware of, especially with physical assessment, is things that indicate potential indicators of pain. So when we're looking at joints, I mean, think about this. Most of us have had some sort of minor injury to a joint, whether it's overextending or a sprain or something. So with the joints, when we look at the joints, they tend to be swollen, inflamed. Inflamed, we would see a red joint. The joint would be erythematous. That would be the term we would use, or warm to the touch. There is a nipple injury, a bone displaced, a knot. For example, somebody misplace their kneecap, and the kneecap is pushed out of place. That would be the injury deformity. The range of motion is decreased, and when we go to feel that pain or feel that joint or try to move that joint, what we find is that it creates pain. So that would be the type of findings that we would see if someone was having those type of things. On the muscles and skin, what we see is bruising, lesions, which would be potentially ulcers or cuts or things like that, wounds, muscles that atrophy. The muscles have gotten smaller because it's hurt too much for them to use it, or so they've immobilized it, so the muscle sort of wastes away. Some bulging, that's due to usually fluid or something that's there. My wife, the little terrier dog that we have, ran full speed into her shin the other day, and she has like a goose egg on the middle of her shin, and that's due to fluid and everything that's created underneath that. In the abdomen, we would look for swelling of the abdomen, where they have accumulation of fluid or maybe even a tumor or something. Any bulging, herniation, especially around the umbilicus or lower the abdomen. If you feel something sort of protruding, typically it's either menum or possibly intestines. The organ enlargement, which you guys, Dr. Davis went over about you palpating organs, and we'll give you a couple of other films if you want to look at those, or videos that I'm going to give you guys to look at later on, not in the class today per se. And then the other things we see a lot of times is pain, typically acute pain response. People's heart rate goes up, blood pressure goes up, cardiac output goes up. That's part of the autonomic response. That can even go higher sometimes when people see blood. And by the way, just as a statement, if you're looking at an injury with blood there, it's like they tell me, there always looks like there's more blood than there is. Blood is dark. It tends to pool, which makes it look like there's a lot more. Typically with pain, people will hypoventilate. It's almost like they hold their breath because they are afraid when they breathe it may hurt. And as a result of this hypoventilation, they may become hypoxic. They will try not to cough because coughing will hurt. We may even have atelectasis, which if you think back could be due to a collapsed lung, which could be due to damage to the pulmonary or to the chest. The GI, typically we find nausea, vomiting, and ileus. Ileus is where that there's pain in the abdomen and it's not moving. Kidneys, people in pain tend, oliguria is they tend to restrict their fluid. They tend to have urinary retention and reduce urination. Musculoskeletal, we talked about, you get some spasms, joint stiffness, typically what occurs. This occurs because you don't want to try to move it. Generally, you have an increased adrenergic response to this. Fear, anxiety, fatigue, pain will wear you out. Pain, your whole body is tense. You're afraid of how bad you hurt or what the consequences are going to be. You get anxious, or you get afraid and anxious over the treatment. That's going to be there. The immune system, pain can sometimes, if it's chronic pain, it impairs cellular immunity. Therefore, wound healing slows down. And with poorly controlled chronic pain, one of the big things we see, quality of life goes down. People get depressed because they think, they're not going to be able to do things anymore. They isolate themselves to try to not move and, not have to deal with people. They get confused because they're focusing on the pain and so forth. So all of these are very common pain responses that we see. This is a good place for us to stop for lunch. So let me just tell you about the rest of the afternoon. The next few slides that we will do are going to be a review of some that Dr. Davis did. I'm just going to hit some high points. At lunch, there is some videos for the speech. If you guys will take a look at that. Those are about, I think there's one in particular that actually shows or visualizes the vocal cords when some of the speech occurs. And I'll have a few other things for you guys to refer to as we go through the rest of the afternoon. But again, there's some of the palpation issues, are some of the palpation slides we've got, which I'm going to go through fairly quickly just to reemphasize some of the stuff that Dr. Davis had. Okay. So I will see you guys at lunch after you finish at lunch at 1 o'clock. And again, I'm going to give you guys time at the end of today to take the post-test, but the post-test will be open until tomorrow. Again, with the post-test, what we're doing is we're not giving you a grade on it, A, B, C, or D, but you get credit for it for CE on that. Okay? Does anybody have any questions? And Karen will probably put those things that you've suggested, or that link that you've suggested on the abdominal palpation. We'll put it up in the resources for that. So thank you. Aiden, anything else we need to do? For just log out and log back in?
Not for now. Just that I have posted all the links for the videos under your name.
Okay.
And they're all there for people.
All right. Sounds good. Well, you guys have a good lunch, and I will see you guys in a little bit over an hour. Make sure you log out and then log back in.
Yeah.